Hello everyone, today we will talk about the history and diagnosis of MDS. The MDS represents a spectrum of stem cell malignancies that manifest dysplastic and ineffective hematopoiesis, which is associated with a variable risk of transformation to acute leukemia. The hallmark of these clone disorders include exaggerated apoptosis of hematopoietic precursors in the marrow, common chromosomal abnormalities, frequent gene mutations, and an increased risk of clone evolution to acute myelogenous leukemia. The major clinical problems include cytopenia and potential to evolve into AML. Let's see the history of MDS. MDS have been subject to confusing and shifting terminology and definitions related to incomplete biological understanding of the disease. In mid-1920s, Di Guglielmo in Naples described a group of marrow disorders associated with bizarrely shaped erythrocyte and cytopenias, which in some cases proved fatal. For many years after, a heterogeneous group of marrow disorders associated with anemia and erythrocyte dysmorphology were called Di Guglielmo syndrome. The first MDS-specific term familiar to contemporary hematologists, refractory anemia, was coined in 1938. In 1942, Chevalier and colleagues in France discussed syndrome they called leukemias. However, this proposal is neglected, partly because the paper was published in French. In 1949, Hamilton Patterson in London used the term pre-leukemic anemia to describe patients with refractory anemia antecedent to AML. In 1953, Block and co-workers in Chicago expanded the concept to include cytopenias of all lineages. In 1956, Björkman in Sweden described 4 cases of idiopathic refractory sideroblast anemia, one of which terminated in AML. In 1963, J.J. Ringgold firstly described a number of patients with acute leukemia of an atypical variety that smoldered along with low-grade clinical intensity for a period of months to years. In 1970, Dreyfus proposed the designation refractory anemia with excess myeloid blast, and in 1976, he and colleagues proposed a preliminary classification of these syndromes. Dreyfus published a paper in which refractory anemia with excess myeloblast was amplified as smoldering acute leukemia. In 1975, at a conference held in Paris, Bassis and Bernard used the term hematopoietic dysplasia, and later shortened to myelodysplasia, for the group of disorders having a more indolent course than AML. In the year following the Paris conference, a group of 7 hematopathologists from France, the United States, England, that's the FAB cooperative group, instituted the classification of acute leukemia. In the FAB classification included 2 pre-leukemic syndromes that should be distinguished from acute leukemia. That's refractory anemia with excess blood and chronic myelomonocytic leukemia. In 1982, the FAB group proposed a specific MDS classification that included 5 entities. In 2008 and 2016, World Health Organization issued new classification of MDS. We'll talk about it in detail later. Let's see how we diagnose MDS. To make a diagnosis of MDS, we have to take all the information into consideration, including clinical manifestations, the morphology of bone marrow and blood, the cytogenetics and gene mutation, etc. The symptoms are usually caused by peripheral cytopenia. The patients may feel fatigue, weakness, exercise intolerance, dizziness, etc. because of anemia. And they can also have fever or infections because of neutropenia or granulocyte dysfunction. Some patients may have bruising, bleeding because of thrombocytopenia. Some patients may have splenomegaly or hepatomegaly because of infiltration. Dysplasia can affect all three lineages seen in bone marrow. The best way to diagnose dysplasia is by morphology and special stains used on the bone marrow aspirate and peripheral blood smear. In the marrow, erythrocyte hyperplasia is frequent, or large or small erythroblast, nuclear fragmentation, nuclear budding, nuclear staining, or internuclear bridging may be seen. Erythroblast may resemble megaloblast, which is referred to megaloblastoid erythropoiesis. Pathologic sideroblast may be identified when marrow is stained with Prussian blue stain. Granulocytic hyperplasia is also frequent. Abnormalities of granulocytes including hypogranulation, hypersegmented or hyposegmented nuclear, a monocytoid appearance of a neutrophilic granulocyte, and acquired pale-acute nuclear abnormality of neutrophils. Marrow biopsy may show abnormal localized immature precursors. Micromegakaryocytes may occur. Megakaryocytes with unilobed or bilobed nuclear may be increased, and hypersegmented or hyposegmented megakaryocyte may be present. The most frequent chromosomal abnormalities seen in MDS are deletions of chromosomal segments or loss of entire chromosome, including del5q, monosomy 7 and del7q, trisomy 8, del20q, chromosome 17 abnormalities. MDS-related chromosomal abnormalities have important clinical significance. They can establish the presence of clonal hematopoiesis. What's more, chromosome abnormalities are key elements in the determination of prognosis, and in the case of del5q, can predict response to a particular treatment. Acquired mutations of individual genes are significantly more common than karyotypic abnormalities in patients with MDS. Gene mutations may affect splicing factors, epigenetic regulators, transcription factors, growth factors, signaling pathways, etc. There are at least 8 recurrently mutated splicing factor genes identified in MDS, and 2/3 of patients will carry on at mutations of a number of this family. Mutations of SF3B1 are present in 20 to 30% of patients and are the only somatic mutations associated with a favorable prognosis. Clinically, mutations of SF3B1 are very tightly associated with the presence of ring sideroblast. SRSF2 is a second frequently mutated splicing factor, present in 10 to 15% of MDS. It is generally associated with an inferior prognosis. Epigenetic regulator mutations, including DNMT3A, TET2, IDH1, IDH2, XO1 mutations. DNMT3A mutations in MDS patients appear to confer a poor prognosis. Clinically, TET2 mutations are not likely driver of MDS prognosis. while XO1 mutations are associated with a poorer prognosis. Mutated transcription factor genes include ETV6, GIT2, and TP53. TP53 mutations are strongly associated with a poor prognosis, independent of other risk factors. Unfortunately, either hypomethylating agents or allogeneic hematopoietic stem cell transplantation can rescue the adverse outcomes associated with mutations of TP53. The mutations of growth factor signaling pathway genes, including activating NRAS mutations and V617F mutations in JET2. Generally, the diagnostic criteria include second, the presence of one or more myelodysplastic syndrome decisive criteria. That's more than 10% dysplastic cells in erythroid, myeloid, and or megakaryocyte lineages. 5 to 19% myroblast. Evidence of a cytogenetic abnormality typical for MDS, such as -7 or del7q, -5 or del5q, T17P. Finally, we should exclusive or alternative diagnosis that explain blood and marrow findings. Okay, that's all for today. Next time, we'll talk about the classification and the treatment of MDS.